My name is Carrie, and I work as a physical therapist. And I'm a little bit curious of how you look upon the field of nutrition.
You have to go louder.
The field of nutrition in the working with diagnosing ADHD.
How I look at what?
Nutrition,
Nutrition.
malnutrition,
Oh, yeah.
nutrition deficiencies like minerals, vitamins, the gut flora imbalance, D vitamin deficiency, and this whole discussion about the rate of inflammation being very, very low, but it's working in your body. But that, so do you have any standpoint or point of view?
Yeah. This was one of the important theories that it might have to do with additives, it might have to do with too much sugar, different vitamins, and it keeps coming up. I just saw an article on this the other day. I don't have an expertise or an opinion, but I tend to be skeptical about everything. And I'm pretty skeptical about diet. I think I'm not skeptical about exercise. So if I had to recommend one thing for a kid with this problem, before medicine, it would be lots of physical activity. One way of looking at it is that, we sort of alluded to this before, our ancestors 50,000 years ago were probably walking 10 miles a day at least. They were constantly active. There wasn't a minute when they weren't doing something to feed the campfire, feed the families. They were on the move. With the agricultural revolution, the type of activity changed, but people were still very active. It was a hard day's work. With the Industrial Revolution, again, different types of physical activity, but a lot of physical activity. It's only fairly recently that the human race has become so inactive. And this probably goes against the grain and need for physical activity in lots of kids. So I think that, and adults, I think that if I were going to be recommending something in terms of a change in daily habit, it would less be diet and much more physical activity. And figuring out which time of the day is most difficult. My granddaughter has a 7 a.m. physical education class. That doesn't make much sense. A physical education class in the middle of the day, allowing a kid to blow off steam, would be much more useful. And the social engineering of classrooms probably gets a lot less attention than giving the few outlying kids a pill. I'm not sure. Diet, I don't have expertise. It doesn't thrill me as a topic. I think if diet were the powerful contributor, we probably know it by now. And the studies are mostly inconsistent and usually not replicated.
My name is Eva Schäfer, and I'm a sociologist. And I would like to ask you, in connection to what you said just now, is that I've been thinking about children and mental disorders. It was unknown in, for instance, Europe during 2,000 years at least, until in the beginning of the 50s, after World War II. It started, MBD like that, and now, after 1980, these excesses of mental disordered children has come about. As a sociologist, I would like to see this as something historical, something social changes. And in the grown-ups' attitudes to children, we don't need them anymore, actually. They're not going to support us. They're not. And we don't need, they are sort of things we show the world. And has that something to do with our obsession with how they behave? Because they misbehaved all the time. You can read St. Augustine, and he said his teachers beated him all the time because he just didn't pay attention. So he never learned Greek because he has such an awful teacher. That's in the 400s. So I think children have been sort of often very disgusting ways of behaving all the time. But why do we think it's a medical? That's my question. What do you think about it?
A fascinating series of thoughts. Why do we have such perfectionistic expectations of children? Why do we expect them to conform to a particular model? Is the medicalization of children even greater than the medicalization of adults? And what would it be that has resulted in this, if it's a factor, in the last 50 years, 60 years or so? It's a very interesting series of questions. My first response is that I think the medicalization of children followed rather than preceded the medicalization of adults. So there may be independent factors in how we regard children, but it may be the tail wagging the dog to focus attention on them and not see the medicalization as an overall aspect of the last 50 years, and the childhood version of it just being a special case. My inclination has been to see it from a slightly different perspective, but it doesn't deny anything you're suggesting. I find what you're suggesting is very interesting. But I've seen it more like the drug companies ran out of adults. They had satiated the market, and just about every adult who could be taking a pill is taking a pill. In the US, at least about 20-25% of the population is taking a psychoactive drug every day. 1/4 of women over 40 is on an antidepressant. 4% of teenagers are on an antidepressant in addition to the ones who are on stimulants, in addition to the ones who are on antipsychotics. I've seen it more that the drug companies work their way down to kids and up to the geriatric populations after they had saturated the adult market. But I think what you're saying is very apropos in a larger sense. That one of the ways of reducing excess diagnosis and excess pill taking is to feel a sense of wonder and gratitude that our kids can be different, rather than expect them each to conform to a particular boring set of expectations. And to appreciate that difference isn't disease, and that kids grow up at different rates, and the different developmental levels of maturity don't represent disease. The kids grow out of things, and that if we're patient, we're going to see changes that, like my teenage sons were a handful. And there was a moment when one of my sons was throwing pebbles at a friend's very fancy car because his little brother had escaped into it. And he's completely thoughtless about the rest of the world. He just wanted to get into that, throw pebbles at that kid. And people would say to me, maybe he needs to be in therapy. And I said, I think he'll grow out of it. And of course he did. A very responsible adult that used to have the expectation, a St. Augustine expectation, that people would sow their wild oats and then become better adults. Spare the rod, spoil the child. And I'm not suggesting we go back to child beating, but there was an expectation that that might be required as a way of disciplining kids, which is now lost. We give them a pill now. We spare the rod and give them a pill. The larger social factors are, of course, important, but I think that I would also add to what you're saying a finer-grained approach. So this country has accepted far more than its fair share of refugees, that you've been the most generous country in the entire world in accepting refugees, that they must come with, they do come, I've heard, with many problems before getting here, based on painful experiences in their home country, painful travels to get here, exploitations and stresses of all sorts, and then they face the terrible trauma of being strangers in a strange land, often without family, without resources, without a comfortable culture. So that we don't have to look, in their case, and I read statistics that show that the refugee population and the socioeconomically deprived population in Sweden is highly overrepresented in the amount of pills prescribed. That we don't have to look at larger sociological trends that may or may not apply to the particulars of Sweden. We just have to look at the kids you're treating and what they've been through to see the social factors that can be easily transformed into medical disorders, mental disorders. And again, it may be that some of these kids absolutely need medicine, that maybe they won't be able to participate in treatment. Otherwise, maybe behavioral control has to be an essential part of their overall management. But my guess is that the medicine becomes a facile way of reducing what would be a better placed investment in a social psychotherapeutic approach. And that we would need sociologists to understand how their particular experiences get translated into symptoms that are maybe better understood as social dysfunction than as mental disorder dysfunction. And that perhaps in this population, more than almost any other, figuring out non-medication ways of providing support is much better than the facile just giving a pill. In the US, there's a tremendous, our problem with the more underserved kids and the kids who have more broad problems is more often cured with antipsychotics than with stimulants. So we have a crazy disproportionate amount. For a while, antipsychotics were amongst the biggest revenue producers in the US. $18 billion a year. Imagine that, $18 billion a year were being spent on antipsychotic medications that have a very narrow indication and should be used at most on maybe 2% of the population. Why so much money spent on them? They were being widely overused to treat conduct disorder in kids, amongst other misuses. Psychiatry's never had a good treatment for conduct disorder. So what was the facile solution? Let's give them antipsychotics. Not knowing at all what the long-term impact of the antipsychotics are on kids, virtually no studies to indicate that this is a good idea, but it becomes the quick response. If you have a symptomatic society with points of disturbance, the easiest thing is to have a doc prescribe a pill. The hardest thing is to figure out what in that society is going wrong and how would you change it. So I would be, if I were auditing, I think one of the things you need to do with medication overuse is do quality assurance audits of the way medicines are prescribed. One of the things I would be looking at in this country would be an audit of the prescription of stimulants, and if you do antipsychotics as well, in kids who are socioeconomically deprived or in refugee situations. My guess is that the biggest misuse would be in those areas where there's the greatest social stress, and where instead of dealing with the underlying problem, the easiest thing to do is give a pill.
Alan and I are both coming from a perspective in which we are looking at the United States as a basis, and then, in contrast, maybe hoping to send a warning to Sweden. I think that's fair. In the spirit of that, before we have our conversation this afternoon, I'm wondering if you could give us an illustration of what the situation looks like now on college campuses in the United States, and how the relationships are emerging between the amphetamines that are the stimulants for ADHD, the corresponding anti-anxieties of benzodiazepines, and the very short distance from there to the opiates and antidepressants. I just, as a personal note, I want to say that I actually have 6 kids. Two are my own and 4 stepkids. My 2 are in the States, and they both have just completed university education on United States campuses. When my son was in grade 5, so he would have been 12, something like that, he almost got a diagnosis of ADHD, but he didn't. That's another whole story. But by the time he got to the upper levels of high school, the kids in his class who had those prescriptions were selling their pills. A bottle of those pills in the States is worth upward of $300 to $400. So for kids on campuses, that's quite a bit of spending money. And the demand for those pills is nothing but increasing. The normalization of using those pills to study for a test is in a kind of a strange contrast and paradox to the idea that long-term use is bad for education, and then we use them for study purposes later. So I'm wondering if you could address this situation, because it's actually alarming. I hope it never happens here.
Yeah, Adderall is now the go-to drug on college campuses and high school. I said 30%, but that's probably an underestimate. Everywhere. We used to drink coffee. Now you pop Adderall. And it's not just for testing, it's also for partying. The drugs do help you focus in the short run. So that, and it's interesting, a lot of ADHD experts will emphasize the fact that the drugs are so helpful in the short run and minimize that there are any risks attached to them. The number of emergency room visits in the States due to stimulant drugs, I think, has quadrupled in the last 5 or 6 years. So that they're not completely benign drugs. Some of the symptoms are anxiety, agitation, insomnia. Some kids become psychotic. Some kids have heart problems as a result of the drugs. It helps to encourage anorexia, which is a big problem on college campuses. These are not benign drugs, and some kids get hooked. You're an addiction guy. Some kids get hooked. There's also, we've sort of changed the complexion of substance abuse in the United States. We've been fighting the wrong war on drugs now for almost 50 years. We've worked very hard to fight the drug cartels, and we've completely lost that battle. Drugs have never been more available or cheaper or more powerful than they are now. At the same time, we've legalized the pharmaceutical industry in a competitive effort, so that at this point, they're actually in some ways more dangerous and almost as ruthless as the drug cartels. The drug companies have pushed opioids in the most scandalous way possible. So we have many millions of people who are addicted to opioids. We have more deaths now from opioids than we do from car accidents, more overdose deaths from opioids than we do from car accidents. Most of these are legal. There are twice as many deaths from prescription opioids as there are from street heroin. We've created a new population of people addicted to opioids because after your tolerance builds up, you can't fill your supply. And either you get turned off by the docs in the drugstore, or it's too expensive. The insurance will only pay for a certain number of prescriptions. You have to start buying it. If you have to buy it out of pocket, heroin is 10 times cheaper. So we have little gray-haired ladies living in the suburbs who never would have been heroin addicts, who now secondarily have become heroin addicts because they originally got an opioid prescription for back pain from doctors who were way too careless in giving out the medicines. And part of why they were way too careless was the drug companies had marketed pain as something that required an opioid, even chronic pain. The benzodiazepines are a complete disaster. I mentioned to someone that I do blogs and I tweet about this stuff. And one of my pet peeves is the legalization of these drugs, legalized speed, legalized opioids, legalized benzos. That the combination you're talking about is the kid who starts getting high on Adderall as part of his college experience, but has to come down, and he comes down with benzodiazepines, which in the United States are also, are they prescribed much here? Oh, so it's not really an issue. Okay, I won't go into it. In the States, 90% of the benzodiazepines are prescribed by primary care doctors, and they're also very much involved. They can't kill you themselves, but in combination with opioids, they're responsible for a fourth of our overdose deaths. In any case, in the US, the DEA, the Drug Enforcement Administration, is doing its very best to reduce the supply of Adderall and other stimulant drugs. They're doing it at the drug company level. They're trying to limit the number of pills they can make. They're actually in a battle with the FDA because the FDA, is saying, the Food and Drug Administration, is saying there aren't enough pills left for the people who really need them. That the market is shifting so that the people who may really need the pills are having trouble getting them, but the pills are readily available on every college campus. It's creating the part of the driver to the ADHD diagnosis is on the demand side. And some of the driving on the demand side is parents who are worried about their kids or people who feel like they need the medicine for themselves. But another part of the demand side is that there's an easy conduit to fame and fortune if you can be the campus supplier of ADHD pills. So you don't have any of this degree of social problem here, but in the spirit of don't do what we do, it's something to worry about. You're very lucky in that there's a filtering system in that only psychiatrists here can give out the medicine, if I have it right. In the United States, 60% of the stimulants, 80% of all psychoactive drugs in America are given by primary care doctors, 80%. 90% of anti-anxiety drugs, 80% of antidepressants, 60% of stimulants, and 50% of antipsychotic drugs are given by primary care doctors, usually after a 7-minute visit. That's the worst possible system. You're a step ahead because you have restrictions that will presumably filter to a smaller group of people who are more careful and better trained before someone gets the pills. And that's a tremendous step forward. But then the next step is to change guidelines so it's not written as if everyone is potential ADHD, and when you don't make the diagnosis, somehow you're missing someone. To have more balanced guidelines.
I work at Stockholm Barnahus, which is the biggest children's advocacy center in Europe. And I work as a social worker there. And for those who don't know what a Barnahus is, we work in cooperation with different authorities. We come together to discuss about children who are victims of domestic violence and sexual abuse in their homes. That will be the police force, district attorney, social workers around the city, children's psychologists, and medicine as well. So we see that a lot of children coming to Barnahus who has, for instance, told a teacher at school that someone did something to me, something that's criminal in their homes, they are actually diagnosed with ADHD, as an example. So the discussion of cause and effect at Barnahus is quite vivid, because we think that is the diagnosis a result of, for instance, ongoing domestic violence prior to the intervention of Barnahus, or is the child's behavior a cause of, or is the violence in the home a result of the child's behavior? But my question to you is, what is your thought about the nature of classic ADHD, like true ADHD?
This is a perfect example of what we were talking about. That we used to call it identified patient. I don't know if that's a term still used. That it's very easy to identify the child as a person, as a patient, give the kid a medicine, and forget all the other stuff that's happening. It's much more difficult to evaluate the whole social setting at home and in the school and in the society. Because here you have this huge influx of refugees. To appreciate that each level is interacting with each other level in the way that you're describing. You don't want to blame the family if the kid's presenting with ADHD. You don't want to make it seem like they're always at fault for the kid's behavior. On the other hand, you don't want to ignore the contributions that may be coming from his day-to-day experience that get reflected in behavior that no longer seems acceptable. So this goes to what I was saying before about diagnosis. Does it make sense to diagnose the kid without doing a family evaluation? I can't imagine ever diagnosing a kid for any problem without a family evaluation. Should there be points for family evaluation before making a diagnosis? Sure. That I would be building a system aligning the incentives of the individuals working within that system to best practice. And to me, best practice would be a thorough evaluation of the entire social context, including family and school, investigating the possibility that stresses within the family or chaos in the school may be responsible for the kids, or his birthday may be responsible for him getting a diagnosis, and postponing the diagnosis until it's been seen whether the social system, the family system, the school system are contributing in a way that can be dealt with that may make the diagnosis completely unnecessary. Changing the kid's class, reducing the family stress, changing the way the family responses to his provocations. That all of these should be considered as possibilities, I think, prior to making the diagnosis of ADHD, certainly prior to giving pills. And I think the advocacy groups can often have more power politically than any professional organization, any professional association can. So if I'm a politician, I'm more likely to listen to someone who's a child advocate than to a psychologist or a psychiatrist. It gives you more standing.
I would be interested in hearing your points of view regarding the associations between early parent-infant disorders and true ADHD, so to speak. The background to my question is that I work a lot with parents and infants where there is a kind of relationship disorder, for example, due to terminated depression or attachment disorders and so on. And if you look at the literature, you can see that there are a fair amount of studies showing a connection between, let's say, postnatal depression and conduct disorders. However, when you present these figures to some authorities on ADHD, they say, well, early relationship disorders have nothing to do with ADHD. It's a disease, it's sui generis, as they say, because conduct disorder and ADHD are two different things. ADHD is one specified disease, and conduct disorder is something else. So what is your perspective on, I mean, my question is not only philosophical, but it is also therapeutic, because if there is a connection between early relationship disorders and later ensuing ADHD, of course it would be worthwhile to put a fair amount of effort into helping these families very early on. I mean, I don't mean when the baby has ADHD, because babies do not have ADHD, but they have other problems, so to speak. Thank you.
I think that's almost a local Swedish habit now. I think that even the most enthusiastic of biological psychiatrists in the States have come around to the idea that everything is much more complicated than they thought and hoped it would be 30 years ago. And that to say that this symptom complex of ADHD is one disease and that symptom complex of conduct disorder is another disease and each has its own brain mechanisms and its own neurotransmitters, just seems to me to be laughable at this point. The neurotransmitter theories of mental disorder have mostly not panned out well. The way I like to put it is that the ancient theory of the four fluids, the humors that controlled our behavior, black bile, yellow bile, blood, and phlegm, creating personality types that were phlegmatic, melancholic, choleric, and sanguine, and interacting in different ways because of imbalances to produce personality disorder and different illnesses. The smartest people in the world for 4,000 years believed that until the early 1800s. And it turns out interesting, plausible, but not true. The smartest people in the world believed the neurotransmitter theory only for about 40 years. And at this point, it's not really seen as at all reasonable to expect any simple one-to-one correlation between a neurotransmitter and a behavior, particularly since the networks are so amazingly complicated. The idea that there's a conduct disorder brain disease, an ADHD brain disease, a major depression brain disease, it's ridiculous. That another way of looking at the diagnostic system is that these are descriptive entities. They're not diseases. They're useful, they're not useful. They don't describe separate conditions. So the way I put this all along is, this is going back to my first papers on diagnosis. Comorbidity doesn't mean that they're two separate conditions. The comorbidity is saying that the person meets diagnostic criteria for more than one of the mental disorder categories. But that doesn't mean they're two separate causes. Very often, the two things labeled will have a unifying underlying explanation and perhaps a unifying, you hope, underlying treatment, because they're just descriptors. They're not diseases. When you have A and B associated with one another, it can be A causing B, it can be B causing A, it can have C causing A and B, or it can be a chance association. Most of what's called comorbidity in psychiatry has to do with a more complex syndrome that has been split into smaller pieces in the DSM system. And the reason why the DSM slices are so narrow is because that increases reliability. When you have a lot of categories, and the DSM has lots of categories, each very specifically defined, and if you have evaluators who do careful evaluations, you find ridiculously high rates of comorbidity with people getting more than one diagnosis. That doesn't at all mean they have more than one disease. It means that they have symptom patterns that are more complicated than the DSM categories. Do you get what I'm saying? Yeah. So the idea that conduct disorder is sui generis this, ADHD that, and these are separate diseases, and that there's a brain disorder causing each of them, is just simple nonsense. I don't think that very many people, maybe outside of Sweden, would be believing that. But then we get to your other question, the specifics of whether, should relational disorders between mothers and kids be treated more actively as a way of preventing later disorders, including ADHD, is a very interesting question I have no expertise on. I don't know if there's a literature on that. It makes sense, but who knows? I'd be especially eager, though, to reduce the intake of cocaine and other substances in pregnant women. That seems obviously important. I think that whether I've worked in programs where there was a very intense effort to change mother-child bonding patterns, and I like very much working in those programs. I don't know the degree to which they actually change later behavior. It's certainly something that deserves lots of research. It's not something I would recommend for every parent at this point. I'm for preventive programs that are simple, straightforward, not expensive. I'm worried about any preventive program that makes claims beyond what's likely to be achieved and will divert resources from treating the people who are already neglected. So I would probably be encouraging research. I'd probably be sympathetic to parental bonding programs, but I wouldn't oversell them until the research is in.
And I have these guidelines here, so we have written. When I come here, I decide I not take the defense, not really defense myself, but more I hear, especially from here, I need to say something about this. I think all can read this from our home site. I think it's this is stepwise. I give you one.
Are these the guidelines you saw?
Yeah, from our association. You can translate it in Google, maybe. Not here, but in the home site. So I would see, when a child comes to us, I'm also describe this medication. And it's horrible that I do that.
You have to go slower and louder.
Okay. It's difficult to speak Swedish in front of a lot of Swedish people. But when the child comes to us, they have a problem. Otherwise, they don't come to us. That's very important. What you say?
Or the parents have a problem.
Or the parents have a problem. Okay. Yeah. And then you have to ask about that. Because I think it's very important that you're screening for a lot of things when it comes the first time. And you have to ask about ADHD, depression, trauma. We are also writing a new guidelines on trauma. We have screening for trauma. And we're screening for depression when we're in the guidelines for depression. We also one of these. So I think it's very important that you screen for a lot of things. A broad picture. And then you also may see that it's the parents' problem. Because I think you have to have four perspectives. I always assess child with a team. A psychiatrist, a social worker, a doctor, and information from school. And it's I always talk to the child alone and to the parents alone. And then you can get, and you have this scale, you call it, what you call it? Checklist scale. But you can't give the diagnosis on a checklist scale. Talk about? Yeah, okay. What's the question? Yeah, okay. Yeah, I just wanted to make to defense of myself to do this. So I don't know what the question is. I think.
No, but I think what you're saying, I think there could be agreement that a thorough evaluation. My guess is if child psychiatrists are doing all of the treatment, that they're seeing a selected group of kids already. It's not like in the United States where it's every kid in the classroom is subject to a GP giving him a prescription. Here the kids are more highly selected. And I guess the point of agreement would be that a thorough evaluation of the kid would include a thorough diagnostic evaluation, but also from a psychiatric standpoint, but would also include an evaluation of the social context, the family context. Yeah. And it depends on how the guidelines are actually applied.
You have been labeling the diagnosis as a potential problem for the individual and the medicine. And you were talking about those 2-3% of the population that actually have the diagnosis. And yet you tell us that there is a problem with the boundaries where what's a sickness, what's a normal and what's not normal. When I see patients coming to me, and I'm working a lot with those kind of problems, there's absolutely no clear cut. What if the patient has a diagnosis or not? But they have a problem. Which of those persons is up for the for the medication. I have to look at the problem and be practical about it. And I think you have mentioned that it's a lot of the schools, the problems that, what do you call it? Let me think about it. I'm very nervous. And it's not only the person's abilities, it's also what the person is about to achieve. So I'm not the only one who's, I can't decide for the person what is your functioning. I have to see of the person's whole situation. The medicine can be very helpful. So it's not an easy decision for me to say that you should not have the medicine or you should have the medicine. I would like you to elaborate a little bit more about the medicine, because I think sometimes they are necessary, and they are necessary for the person to be able to take in the information and the education and change that they have to do in themselves. Thank you.
Did everyone hear that? My ears are old, so sometimes I have trouble, but did you all hear it?
Yes.
Okay. Yeah, it's basically the crucial question: who to treat, who not to treat. You come right down to it, that's where the rubber hits the road. Unfortunately, there's no gold standard for deciding who has a disorder and who doesn't. There's not a bright line that separates normal from abnormal. It's particularly difficult in the situation that you're facing in this country now with a very large number of refugees, because they will most likely be candidates for diagnosis. They may have terrific social problems, and sometimes it's hard to distinguish what are the social problems from what's the psychiatric problem. And I read a recent paper done here, translated for me kindly by Lena, that showed that the rates of diagnosis are much higher in lower socioeconomic classes, in kids who are living in residential settings. The people in the Swedish society who are least integrated into the society are most likely to get the diagnosis. And this is very true also in the United States. People with conduct problems will very likely get a diagnosis and be treated with medication. In the United States, there's a tremendous problem with the overuse of antipsychotics in kids. Is that true here or not a problem here? Much less a problem here? Okay, so the question comes, you're seeing a patient in the office, you have a limited amount of time, you have to make a decision. Is this someone who I should give a diagnosis to, or is this part of normal variation, or part of developmental discontent, or part of a classroom problem more than a kid problem? And how do you make these decisions? In an ideal world, which this world isn't, but in an ideal world, I would say this is not a decision that should be made on the first visit. And maybe it's not a decision that should be made on the second, third, or fourth visit. That it would be useful to have a longitudinal approach to the child to make sure that the symptoms are persistent enough, are pervasive enough. ADHD is not supposed to be just in one environment. If a kid is having trouble with school, but not having trouble anywhere else, that's more of an adjustment problem to school than ADHD. It's supposed to be pervasive, something that's brought by the child to all situations, not a specific reaction to one situation. And again, this may be hard to judge on the first visit. It takes time to see. The symptoms should be disabling. They should cause significant impairment. It shouldn't just be individual difference. It shouldn't just be he's the youngest kid in the class. In fact, that would be one question I would always ask. Always ask the birthday in relation to the cutoff day, because the judgment about the child is going to be distorted, but from the parent's point of view and from the school's point of view, if he's the youngest kid in the class. I'd have a different diagnostic criteria for the youngest kid in the class than I would the oldest. And I don't know how this system works. Ideally, it would be useful if there's more of a team approach in the diagnosis and in the treatment. So it shouldn't just be a question of medicine or no medicine. It should be, let's try all of these other things first and see how far the person gets. That if with normalization, with education about individual difference, parent training, how can we better deal with, which situations are bothering you the most? And figuring out ways of dealing with them differently. With environmental manipulation, like I was told that we should have a short break at 11 o'clock so people can stretch their legs. Now what does that mean? It means that there are people in this audience who would find it difficult to sit in a classroom for 3 straight hours without a break. What do we expect our kids to do? The environmental manipulations, more physical activity, more time, free time. Computers are often very helpful with kids with ADHD. They may not be able to focus on other things, but can focus on computers quite well. Environmental manipulations. Is there family distress? Is there social distress? Because the kid's just come all the way from Afghanistan, and along the way he's been beaten up or sexually abused. That all of these would go into the evaluation and efforts to ameliorate the difficulties in the social context, to reduce the stressors, to provide increased support, are tried first. And at the end of the day, if these haven't worked, then a diagnosis and then the medication. So this is what Laura and I call step diagnosis, where it's not an individual decision on a first visit made by a psychiatrist and a patient, or in America very often a pediatrician and a patient, that you have time. Now in America this is difficult to do. And I think you have a similar problem here, that if you don't make a diagnosis in America, you don't get paid. And I heard you have a point system here, and that to get maximum points, it's important that the person have a diagnosis. I think that this is something to fight against, that whenever there's a financial incentive for a diagnosis, whether it's a financial incentive for the doctor, or a financial incentive for the school system, or a financial incentive for the parents, or other incentives, like ADHD in the States often results in extra school attention, more time for tests. Whenever there are incentives for a diagnosis, the rate of that diagnosis goes up. And in an ideal system, you don't want to label kids having a mental disorder, because that's much more expensive lifetime than interventions that may isolate the problem to that moment. So one of the things that makes sense for a system to look at, although almost never do they do this, is I'm not just interested in the short-term costs of care, I'm interested in the long-term costs of care. It's more expensive to do a thorough evaluation than to do a quick evaluation. It may require having a family contact. It may require having a series of therapy sessions. And in the short run, that's much more expensive. But in the long run, medication's more expensive. And I think that my advice to systems is to invest more in the diagnostic process so that you don't make a quick diagnosis. Because once the diagnosis is made, it can have lifetime implications. And from a society's point of view, a lot of those are negative economically. That it's worthwhile, even if you don't care about people, even if all you care about is cost, the best way of apportioning resources is to spend more money at the beginning, because that will cost less in the long run. In our system, all the rewards are to a short-term diagnosis. And that's bad for everyone. We have to realize that we know very little, really almost nothing, about the long-term implications of bathing immature brains with very powerful chemicals. That the things we have learned are not encouraging. There was a hope that medication would improve long-term academic functioning. Turns out it doesn't. That it reduces the kid's disruptiveness in the short run. But the law, and when the first studies were done, Keith Connors was actually one of the principals in this study. There was a multinational, a multi-site NIMH study in America. And the first result, it was comparing behavior therapy, cognitive behavior therapy with meds. The first result reported was very dramatically that meds were better. But when they did follow-ups on the kids, the advantage to meds started disappearing, and the medication did not improve academic performance. That the therapeutic interventions don't show as much of an immediate impact, but may be more enduring. So I'm not sure if this is an answer to your question, but the system should allow as much time as possible with as many resources as possible so that you're not alone in doing a thorough evaluation and in trying everything else first before the last resort, which would be the diagnosis and the treatment. Now, there may be some kids that are so classic that there's no question. And the more severe, the earlier the onset, the more persistent, the more likely you're going to feel comfortable making a diagnosis. But for the gray area kids, the more time, the better. And the thing we have to realize is the percentage of kids who will present with very severe symptoms is going to be that very small 2%. The percentage of kids who are getting the diagnosis, that's very large now in the US, 13%. And maybe in Sweden, 4 or 5 or 6%, who knows, extra. The kids who have a questionable diagnosis are much more commonly encountered than the kids who have a definite diagnosis. So that with the gray area where you're not sure, the longer you can postpone it, the better. And the more the system allows you to postpone it without penalty, the better. So one of the things I recommend in every country, and I don't know whether it has any effect, but in every country I always recommend don't force clinicians to a fast diagnosis. Align the economic incentives so that they can have more time talking to the patient. The more time clinicians have talking to a patient at the beginning, whether it's in psychiatry or internal medicine or surgery or any specialty, the more time the doctors spend talking to the patients, the fewer tests they order and the fewer procedures. The less time, the quicker you are to medication, testing, treatments. And we lose the more we lose the human touch, the more we lose the relationship aspect of really knowing the people we're talking to in a personal level, the more likely we are to jump to a diagnosis and to a pill because we have nothing else to offer. The more we focus our attention on the doctor-patient relationship, which is what doctors have always done. We've never had active medicines in the history of medicine going back 50,000 years. But doctors have always been an important part of a patient's life because of the relationship, because of the hope, the magic, the feeling of being understood, the empathy. The more we lose that into a checklist of quick diagnosis, not saying you do it, but just in general, the more we go to checklist diagnosis and quick treatments, the more we lose the magic of the relationship. And one of the ways I put this is I would not trust someone who doesn't know a criteria set for diagnosis. It doesn't matter whether it's DSM or ICD, but everyone should know how to make a criteria-based diagnosis. If you don't know that, you're idiosyncratic. You're just making it up as you go along. On the other hand, I would never trust someone who only knew a criteria-based system of diagnosis. If you're just doing checklists and deciding about side effects and ordering pills, you're losing the social context and the psychological context that are equally or maybe sometimes much more important. A rounded clinician knows both. And the biggest tragedy, I think, in our field has been reductionism. That we have, and you have in Sweden, I've just been reading about it, you have in Sweden a tendency, like ours, to have extremists on both sides of questions act as if they know the truth. And anyone who has a biological reductionism obviously is missing all the important stuff of social and psychological functioning. On the other hand, anyone who has a psychosocial reductionism is missing the fact that there's a strong biological component to all of human behavior. That people who are sensible have a biopsychosocial model that combines every aspect of human existence in every evaluation. That doesn't come down too easily on this is just a brain disease or this is just stress and has nothing to do with individual endowment. I think every sensible clinician will combine all of the different points of view and appreciate the complexity and the beauty of human behavior, the importance of the relationship, and will act not just as a pill pusher on the one hand, act not just as if, well, this is all myth, no one ever has these symptoms, no one ever needs medication. People who take extreme views in either, the only way you can be wrong in our field is being sure you're right in an extreme position. Because in almost everything we do, there are such subtle shades of gray. Does that approach an answer to? Do you have a response?
I think I get them after they have been to the child psychiatrist. I think they are doing a great job in child psychiatry in Sweden. They are doing very far investigation before they say that the person has ADHD or some other problems. I'm worried about people are afraid to go to a psychiatrist and get this investigation because I think that's crucial. We have a survey here in Sweden in Yale prisoners, and there was a high amount of persons with ADHD there. Whether or not they had ADHD, I think they had it because there were a clinical evaluation, and it was 46% of the prisoners that met up the criteria. And I think it's a very high risk if you don't get help. And in child psychiatrists in Sweden, they do a very thorough evaluation, much like what you are asking for and augmenting for. Not just one call. It takes a lot of days, a lot of times with the psychologists and the doctors, and they call in the teachers and so on. It's in adult psychiatry, it's a problem. There were investigations on that too, and the range was between 1 hour up to 20 hours for a diagnosis. And there we have a problem. And it's a problem because not long ago it was special clinics doing those diagnoses. Now it's spread on every open care clinic. And that means that a lot of persons without much knowledge and experience are doing those diagnosis investigations. So there has been more of a misdiagnosis, but I think it's a problem if we don't do those investigations. We have to help people, and that's something. It's important that people that they are not afraid to go to get an evaluation. And then I agree that it's a problem if we look at that point and the cost and all those factors you were talking about. That's a problem, a little problem in Sweden too.
And I don't agree with my colleague here because we don't do good work in child psychiatry in Sweden. That I worked in University Hospital in Örebro, 40% of the child had this ADHD diagnosis, and it was wrong in many times. I could discover a lot of traumas they had missed. And it's not true that they do a good job because we have high doctors come just one day and take a lot of ADHD diagnosis. So it's not true what you say. And even so, there was 3 professors who written in our professional journal, you should not take that long time to diagnose it.
They said what?
They said we should not allow that long time to make a diagnosis.
Why?
Even because it's easy to make it.
It's so simple.
Yeah, it's so simple. And I will ask you, Alan, because now in Sweden they say, well, girls, they can manage in school because they can compensate for that. So they don't even have to have the problem in 2 areas. So that they are really extending long far away. And I think it's a very bad situation in Sweden, and it's even worse.
The person most responsible for spreading the ADHD epidemic in the United States was regarded as the best expert, or one of the best experts in the United States. And I just want to reiterate what I said earlier about caution in regard to experts. that if you love a disorder, it becomes like a pet or a child. And you start seeing it everywhere. If you have a hammer, you're looking for nails. And the interesting thing that I've discovered as I get older is that many of the people who were most enthusiastic when they were younger come to regret it as they get older. Keith Connors is a good example of that. The regret isn't so much that he wasn't doing or saying the right things along the way in his career. The regret is how what he was saying has been misunderstood and misapplied and exaggerated and used as a explanation for everything. So I think that you have to be careful with people very inexpert making the diagnosis. Not necessarily, you wouldn't trust someone who doesn't know what he's talking about. But you can't always trust the expert in an area because he will have a conflict of interest. Some of these conflicts of interest are financial, because sometimes the experts are very much involved with the drug companies. But even if there isn't a financial conflict of interest, there's almost always an intellectual and emotional conflict of interest, that you're very attached to your area, that becomes part of your life, part of your identity. And again, I would always be going for people to trust. When I've had to ask questions, I always go for people who take a middle view, who sort of can see both sides of every question and come up with a consensus opinion that makes sense. That I would always be very cautious about anyone who says ADHD doesn't exist. That's a meaningless statement. These are all constructs. It certainly exists as a construct. The question for someone who says it's never useful, I think they haven't seen enough patients. On the other hand, someone who sees ADHD with everyone has obviously a strong conflict of interest powerfully for it. And one of the problems is that the thought leaders tend to be listened to too much. And often they control policy, they control guidelines. In the work with DSM-4, I had to work with 1,000 experts, and I worked closely with DSM-3 and 3R, again, thousands of people. And you discover in the work with a large number of people who you can trust and who you can't. And very often you have to be careful not to have the whole field following a Pied Piper. And you may have had some of that in Sweden. It's very important that the policies, that the guidelines, the treatment guidelines, that the policies reflect a common sense middle position rather than extremism in either direction.
I would say that the new guidelines in Sweden does not reflect the middle position. The aim of the new guidelines is to not miss this diagnosis.
Not miss?
Not miss it.
Yeah.
Because we shall ask every child about these symptoms of hyperactivity and these things, which are also, as you said, in many other diseases. So they miss it too much, I think.
Just to repeat it, experts always worry about missed patients, never worry about mislabeling. General rule of thumb about experts. But this leads to another question. Should we be testing kids early? In some countries, they're now beginning to test kids at 3 or 4 to see if they have psychiatric disorder. This is a horrible idea. Kids are very changeable. The predictive validity of early diagnostic evaluations will be remarkably low. You'll wind up misidentifying very large numbers of kids, subjecting them to the stigma and problems with excessive treatment. And everything that spends money doing that is depriving money from other things that are more important. So I would much rather be devoting more money, more resources to kids who have real symptoms, getting them early. It's important to get symptoms early, but not to try to predict them before they're there. And providing them with enough resources, all the things we've talked about, rather than inventing new cases. And anyone at this point who says we need to be diagnosing more doesn't make sense. I mean, like, when we started with DSM-4 in '87, you could conceivably make an argument that the bigger problem was misdiagnosis. But at this point, with the tremendous increase in rates, it's obvious that the bigger problem now is the mislabeling. And there's a terrible paradox. There's a tendency for the kids who need it most, for people who need it most, not to get the treatment. That if we have a shotgun approach where the diagnosis is seen as being ever present and we have to start labeling more people, we'll often miss the ones who really need the help and give them insufficient help. And another point related to this, in the United States, we spend an enormous amount on medical treatment and a very small amount on social services. Europe, and especially the Nordic countries, spends much less on medical treatment and much more on social services. If you look at the per capita total spending, medicine plus social services, it's about the same. But our proportion is much more to medical treatment. Your proportion is much more to social services. The interesting thing in this is that the medical outcomes are much better here. That if you spend too much money on medical treatment, you wind up over-treating people who don't need it. The treatments themselves are often worse than the diseases that are being supposedly treated. If you provide more social services, a very large percent, some people think 80% of the health of a country is determined not by its medical treatment, but by its social services. Applying that to the ADHD question, I'd much rather there be intense services to help integrate refugees into Swedish society, making sure that they're learning the language, that that they feel included, that they're part of the society, than giving them a pill. That the easiest way to deal with someone who presents with a problem is to give them a pill, but often it's the least effective way of dealing with it. So that the $13 billion we're spending for pills, and you're spending a small fraction of that, but these are not cheap pills. I would prefer that these were spent, most of them, for social services, and only the portion that's going to treating the kids where the problem comes from within the kid, not so much from within the social context. We also don't have any knowledge about the long-term impact on the brain. So this is like a experiment. It's a public experiment in the United States, including millions and millions of kids, without any knowledge really about what the impact will be. In the United States, it's gone to the ridiculous extreme that we have 10,000 toddlers, 2 and 3 years old, on stimulants. Can you imagine that? Now the recommendations are 4 years old or above in the US. Even 4 strikes me as being young, except for very extreme cases. But it's hard for me to picture the cases where a 2-year-old is going to be on a pill. We need to be aware of the risks of treatment, and everyone needs to be more afraid of treatment than we are, and somewhat less afraid of difference and of disorder.
I appreciate when you talk about the financial situation, and I think it's important and that we should focus on the bureaucratic aspects that all of us are parts of, and that foster the approach to the individual. As a matter of fact, which we all know, registering the consultations, you register the single person, and you get less points if you approach the group, the classroom, or the family. So when people come, they are greeted as the individual, and I think it's so important to find a way to inform what the costs are of this. And I think it's very good, and I think it would be very valuable if your knowledge and the position and your if it would be possible to get on a political level.
Who decides the points?
National Health Services, and it's almost impossible to change that. I think if you meet a person in a group, for example, I think you get half a point for each person. And I think, within the bureaucratic system, my colleagues talk about how this is manipulated in many ways to cover up so it's possible to get the points that you expected to have each day.
Yeah.
And it's such a disastrous aspect.
One of the things...
I think what we talk about here, I think we can share the aspects you bring up. But I think the bureaucratic system is really something to join and find ways to have a dialogue and find other ways of thinking.
One of the general rules of thumb is that all medical systems, and especially all mental health systems, are terribly irrational. That if there's a place we would look towards as the most rational place in the world, it would be Sweden. The Nordic countries tend to be much more rational in your attitude toward and methods of doing government than the rest of the world. If yours seems irrational, you can't believe what it's like in the United States. One of the problems is a tendency for other countries to copy things in the United States that make no sense. I noticed on my last visit an increasing privatization of services. That's a terrible mistake. What happens when you privatize mental health services is that the people who most need them are the ones frozen out. That the easiest patients to treat, the ones you can get the most points per hour treating, the least expensive, are the people who least need it. And what happens in any privatized system is a cherry picking of the easiest patients and the best ways of gaining points or dollars per minute in treating them. The whole idea of having a public system is to correct the other inequalities in the society and to try to provide a safety net for those people who are most in need and who won't get adequate treatment if everything is determined by dollars and cents. But then it becomes very much an issue of how are the incentives aligned in your system, and do they reward the care of the people who most need it in the way that's most efficient to treat them. Every system is usually a result of historical accretion and political power. Very rarely, like the best example of this is how we have a terrific abundance of medical specialists everywhere in the world and a terrific shortage of primary care doctors. In the best of all possible worlds, there would be many more primary care doctors everywhere and fewer specialists. But the medical schools are controlled by specialists everywhere in the world. And the specialists control the medical societies. And the medical societies control the lobbying of the politicians. And the politicians, therefore, assign points for procedures rather than for contacts with patients. The problem here with ADHD is not unique. It's part of a worldwide problem that incentives don't necessarily follow the needs of the patient. They often follow the needs of the system and the people most powerful in controlling the system. How to develop a more rational approach? What?
5 minutes bone stretcher?
Say again?
The 5-minute pause.
Yeah, we'll do the 5-minute pause in a minute. Some of you may be getting restless and maybe didn't take your pill this morning. And so we'll give you a pause. How do we deal with the irrationalities of any system? With difficulty. Entrenched forces. The reason something is the way it is usually is not just accident. It's usually serving powerful interests. And the analogy I like best here is David versus Goliath. That individual people, however well-meaning, have only pebbles against a giant. However, David sometimes wins. David won. The tobacco industry was a giant that's been tamed. And it's conceivable that what we call the medical industrial complex in America may eventually be tamed. If things get so outrageously stupid that it's hard to find a defense for them. It's clear, though, that one of the great obstacles to change in any system, any mental health system, is that the different professions often don't talk to each other, don't cooperate, and even worse, may be very competitive. Understandably so, to the degree that they're competing for shrinking pieces, or pieces of a shrinking pie. And that everyone will tend to, for strictly mercenary reasons or idealistic reasons, if they identify their interests as being the right ones, each group may be fighting to protect their particular turf in a situation where resources are scarce, which they always are, and where the apportionment of those resources is up for grabs. For a system to become rational, it really does require that the different professions work together to figure out a way of doing something that's best for the patients. Theoretically, that's why we're here, to figure out what's best for them, not necessarily what's best for us as professionals, and to develop a system that goes from patient need to delivery of service rather than from professional need to working downward to how what we like to do becomes what the patients get. And the thing that works in some places but doesn't in others is regular it's nice that this audience has such representation, but it's not enough. It's not just a group of people. It would have to be the leadership people in the different professions coming together with a much more ecumenical view to developing guidelines. It wouldn't be any one group that says, we're just underestimating this, everyone needs the diagnosis. There would be the voices, your voice, other people's voices in the other direction, to come up with some consensus approach, a set of guidelines that isn't as one-sided as you're making the Swedish guidelines sound. I haven't read them. But if they're as one-sided as you're making them sound, this makes no sense. And there wouldn't be one small group that dominates the guideline discussion. It would be the comprehensive inclusion of all the interested parties, including the patient groups, coming up with a set of guidelines that seems reasonable, and then developing a point system that satisfied the needs of the patient through aligning the incentives of the professional to those needs rather than the other way around. How to get from here to there is more a political question than an intellectual question. What to do is usually not rocket science. It's not difficult. Practically figuring out who the power people are in the system and figuring out how best to get their needs congruent with the needs of the patient, that's a very tough problem. But not impossible when the needs of the patients are being egregiously missed or misunderstood. So at a certain point, like in our situation with 15% of kids getting a diagnosis, amongst adolescent boys in the US, 20% get the diagnosis of ADHD and 10% are on medication. Think about that. 1 out of every 5 boys theoretically has this mental disorder. When it reaches that degree of egregious stupidity, the society begins to respond to it. And you start getting a backlash. And the press starts writing about no longer the miracle drugs for ADHD. The press starts writing about this is crazy. The media starts, and the politicians only respond when they feel a sense that they have to. They'll be the last people to respond to the truth. So it depends on how outrageous it feels in Sweden. How ridiculous does it seem? How many reporters start reporting how ridiculous this is? When you start having examples in the newspaper of kids whose lives have been hurt rather than helped, then public outrage gradually boils up and it affects behaviors. You're not going to have a turn for a while. You had your turn. So you get the last question. So I don't know what could come of this meeting except an urge for people to begin discussing what's wrong with the current system, and not just to complain about it, but to figure out what you could do to change it.